Thank you for joining us today for a webinar with VCU alumni called The Future of Testing During COVID-19, a conversation with medical laboratory science experts. My name is Dr. Amy Gray-Beck. I'm the Executive Director for Alumni Relations at VCU and a proud alumna of the School of Education from 2019. We will be recording this webinar and captioning it and sharing it on our YouTube channel for later viewing. You can catch all of our previous virtual programs and Q&As on the VCU Alumni YouTube channel. VCU Alumni has been offering a number of virtual lifelong learning and personal and professional development webinars. And the next event we have is on September 21st, and it's called The Right to Vote, Election Integrity and Advocacy. And it's in conjunction with National Voter Registration Day, which is the following day on September 22nd. So we hope that you will join us for that event as well. Today, we have some questions to get us kicked off, in addition to some that you submitted on the registration form. But attendees can put questions in the chat feature or in the Q&A feature on the webinar or in the Facebook comments, and we will get them as soon as time permits. Now, to get started, I'd like to introduce our moderator for this afternoon, Dr. Bill Corzin, who's the Associate Professor of Clinical Chemistry at VCU. Dr. Corzin has been involved in clinical laboratory science for over 45 years as a student, technologist, clinical chemist, and educator. He earned his bachelor's degree in biology from Rutgers University, a certificate in medical technology from the Hospital Center at Orange, New Jersey, his master's degree in medical technology from Temple University, and his doctorate in pathology and clinical chemistry from the Medical College of Virginia at Virginia Commonwealth University. Dr. Corzin is active in the American Association for Clinical Chemistry, the American Society for Clinical Laboratory Sciences, and the Richmond Society of Clinical Laboratory Sciences. Dr. Corzin, welcome, and thank you for moderating our expert panel today. And I'll turn it over to you.
Most welcome. There's been a lot of discussion in the media about the importance of lab testing in fighting the COVID-19 pandemic. Most people, however, think of the clinical laboratory as a magic black box where you shove a sample in one side and out comes the magically correct answer from the other side. But they don't know that there's, to get lab results that are reliable enough to inform treatment decisions and public health strategies, we need the proper instruments, we need validated chemical and biological reagents, and we need qualified laboratory professionals to perform the test, develop the tests, and also manage the testing process. So I'm delighted to have 4 experts in the field of laboratory medicine with me today who can answer questions about the testing process and what's been happening with respect to the pandemic. So my first panelist is Dr. Marilyn Bibbs Freeman. Dr. Freeman also happened to have earned her master's degree in clinical lab science here at VCU in 2001. And she is currently the Deputy Director, Department of General Services and Division of Consolidated Laboratory Services for the Commonwealth of Virginia. Dr. Bibbs Freeman, can you tell the audience a little bit about yourself and how you're involved in the testing process?
Absolutely. Good afternoon, everyone. So here at the Department of General Services, Division of Consolidated Laboratory Services, we've been very busy planning here since March for COVID-19. In regards specifically to what I do here, I kind of see myself as the middle woman. I support Dr. Toney in her efforts to be our leader here at the laboratory as it applies to COVID-19, but I also serve as a logistical liaison here with our different functional areas. And so we've divided the COVID-19 testing process up into a number of areas. To name a few, they include our kits and accessioning area, which means the team that just receives the samples in and disperses them to the testing lab. We also have our testing laboratory, our data entry laboratory, and we also have a call team, fax team that was initially helping with getting reports to our submitters and clients very quickly. So if I could wrap it all up and say what my main Responsibility here is really to act as the liaison to Dr. Toney so that she has the information she needs for our agency director as well as our other partners, but also to act as a point person in our administrative area for our different functional areas for COVID-19.
Thank you, Dr. Viv Freeman. Our second panelist is Dr. Denise Toney. She is an alumnus of the School of Medicine of VCU, 1993, and she is the laboratory director in the Department of General Services, Division of Consolidated Laboratory Services. Dr. Toney, can you tell us a little bit about how you're involved in this whole process?
Sure. Well, good afternoon. With respect to my responsibilities for COVID-19 response, as Dr. Viv Freeman has alluded to, she has responsibility for the day-to-day operations. My responsibility as director is to make sure that our laboratory is providing for the Commonwealth all the testing that public health needs to respond to the COVID pandemic. But for my role, it is more serving as the point person to all of our customers and our stakeholders and partners outside of the laboratory. It's partnering with the public health community, the hospital community, emergency response, making sure that we are at the table for discussions as to what the Commonwealth needs for laboratory testing, that we are partnering with respect to logistics, with respect to state testing needs, and coordinating a state response that is seamless, that is collaborative and coordinated, and that everyone that is responding to COVID-19 is well informed and is working in partnership to make sure that the citizens of the Commonwealth get laboratory testing services that they need, and supplies and all the other things that go into making sure that we are tackling this virus as successfully as we can.
Thank you, Dr. Toney. Our next panelist is Ms. Roxanne Mercer. Ms. Mercer is a graduate of both the bachelor's and master's degree program in clinical laboratory sciences here at VCU, and she is currently the director of laboratory operations in the Department of Pathology at VCU Health. Can you tell us a little bit about your responsibilities, Ms. Mercer?
Sure. So good afternoon, everybody. My role is really as an operations director. I get to work with a very talented group of medical directors, PhD scientists, managers, and technologists, really to coordinate efforts around provision of testing. So that includes, staffing, making sure we have the team that we need who are well prepared as far as PPE, training on donning and doffing, have all the necessary safety precautions in place to make sure that they can do their job appropriately. I also work with procurement as far as obtaining equipment, reagents and supplies. I also work in a role as being the coordinator with outside organizations who want to send us testing. So couriers, requisitions, interfaces, coordinating all of those efforts with our internal teams who provide the service.
Thank you, Ms. Mercer. And finally, we have Dr. Alexandra Bryson, who's an assistant professor of pathology and the associate director of clinical microbiology in the Department of Pathology at VCU Health. Dr. Bryson?
Hi, thank you for having me here today. My role in the COVID testing is really for the VCU Health System diagnostic testing for our patients. I'm the associate director of our clinical microbiology laboratory. Early on in the pandemic, our laboratory developed our own molecular-based assay to detect SARS-CoV-2, which is the virus that causes COVID-19. And since then, we've added on additional testing capacity through commercially available tests and also working with our molecular diagnostic lab to ensure that we have enough testing and are providing a good turnaround time for everyone who shows up to our health system who needs a COVID-19 molecular test.
Thank you, Dr. Bryson. So my first question to the group is, when is it appropriate to test for the virus? And when is it appropriate to test for antibodies to the virus? Dr. Bryson, can you kick it off for us?
Sure. So if we want to diagnose an active infection, we want to use a molecular test, or PCR. PCR stands for polymerase chain reaction. That's how we amplify the genetic material of the virus that causes COVID-19. So if you're looking for an active infection, you want to use the PCR. The serology is really more of a prevalence tool. People don't develop antibodies for COVID-19 until about 14, 15 days after they've started showing symptoms. And so really most people have cleared their infection, or we already know that they've gotten an infection by the time that their antibodies are positive. And so using serology really just helps give us an idea of how many people have been exposed to the virus and developed an immune response. So we're really measuring two different things. With a molecular assay, you're looking for the virus itself, and with a serologic assay, you're looking for the body's response to having seen the virus itself. And so if somebody's recently been exposed and showing their symptoms, their serology is likely going to be negative for the first 2 weeks. So it doesn't really help in making an immediate diagnosis.
Thank you. I have a question for either Dr. Toney or Dr. Viv Freeman. What method are you currently using at DCLS to test for the virus? And then Dr. Bryson, can you chime in to see, is that the same method that you're using, or are there different methods for testing for the virus out there?
I'll take it. We are actually using a variety of methods here for polymerase chain reaction, or PCR. We initially started with the CDC method that was distributed to all public health laboratories. Subsequent to that, we actually brought on the Thermo Fisher TaqPath assay, and we have just recently received a system called Pneumatics that will be a self-contained, fully processing both extraction and PCR instrumentation. So we have two methods that are being used currently, and a third method that will be on board soon.
Thank you.
Here for the VCU health system, we initially started with our own laboratory developed test, which was a modification of that CDC assay. Since then, we've also added on the Cepheid rapid assay. We're also doing the Thermo Fisher assay that the state lab is using. We have the Abbott, Roche Cobas assay as well in our molecular laboratory. And we do have the BioFire film array, which we use their original individual assay, and we do have their new combined multiplex panels available. So one thing that I just want to highlight to everyone is usually most diagnostic laboratories have one assay to diagnose a particular infection. And the fact that both of our laboratories here just mentioned multiple assays that we're working with highlights that we have limited reagents on every single platform, which is why VCU is running 5 different platforms to meet testing needs, because each one is reagent limited and you have to sum them all up together to get enough to test our population.
Thank you. Dr. Toney, can you tell us what are the, now that we're testing more asymptomatic patients, what are the major sources of false positive test results and false negative test results?
So I think that there can be a lot of sources for false positives and false negatives. So I'll start with false negatives. When you're testing asymptomatic individuals, if you test a person that is possibly either too early in their infection, with a PCR test, you are testing for the presence of the virus. So if they have just become exposed, the virus has entered their body, but the virus hasn't had an opportunity to replicate and divide. And so you may not have enough virus there to be detected by the test that you're performing. And so you could potentially get a false negative because you need some time for that virus to continue to grow to a point where your test system can detect it. Also, the same thing can happen if you test a person that has been sick for a very long time and then maybe they've recovered. You could get a false negative. They've been sick and they're no longer sick, and so they could get a negative test. A false positive can happen. You could have a person that has been sick, they have recovered, and they have dead virus that is still in their system, and the PCR tests that we use do not distinguish between live virus and dead virus. And so even though it's detecting the presence of virus, it could be dead virus. And so the person is not infectious, but the test system is still detecting residual virus that is in the person's body, but they're not really infectious. And so it's considered a false positive in the sense that they're not infectious to other people, but there's still virus in their system. Those are two examples.
Okay, thanks. Ms. Mercer, Dr. Bryson alluded to the supply chain issues with testing. Do you think that VCU Health laboratories are running at full capacity right now, or are they still trying to make up ground?
So right now, I would say the limiting factor is supply chain issues. Sure, we could probably do more tests, but I think one of our top priorities is making sure that we always have the ability and the capacity to take care of our patients. So we want to be able to test the symptomatic patients who are coming in, so that we can determine, are they really infectious? Do they need to have all of the personal protective equipment to keep the nurses and the doctors safe? Or we've also been testing asymptomatic patients who are having surgery here, and so we want to make sure that we're protecting our ability to not only test all of those patients, but also provide a turnaround time that's meaningful. So I would say right now, the limiting factors really are the ability to get equipment. We place orders, but everybody's placing orders right now. So, you're pretty much in the queue. And also a lot of the vendors, as far as reagents, are allocating supplies. And so the people who are in real hot zones are getting a lot more materials than we are right now. And so staffing is another concern. We've been doing this since March, so the team is really burned out. And so how do we take care of our team, not only to keep them safe as far as not getting COVID, but also mentally focused and able to do a good job every day?
Thank you, Ms. Mercer. One of the strategies that has been proposed to be able to do more testing more rapidly is to pool specimens together and test the pool instead of the individual specimens. Dr. Freeman, do you have any thoughts on that? Are there advantages and disadvantages to doing that?
So there are definitely advantages and disadvantages to pooling. We are awaiting additional guidance before we here at DCLS may take that step. But I will say, from an advantage standpoint, it allows us to, or would allow a laboratory to get more throughput. They will be able to test more samples, theoretically for less money, if a pooling strategy is taken on. Speaking as a laboratorian, pooling always makes me nervous. You have the potential that samples may be diluted out, and then you begin to get into the situation where you have false negatives, as Dr. Toney kind of alluded to earlier. And so, I do think that it has its place, but there are other considerations that need to be thought about before it's implemented. One of the things that the Food and Drug Administration, as well as CDC, cautions against is that if your incidence level of disease, so the number of people or cases that you have in a population, is over a certain level, it really actually isn't gainful to pool. you will find yourself pooling the samples and then splitting them back out more frequently than if your incidence rates were lower.
Another thing that's been purported to address the testing availability is there's rapid point of care tests for the virus, as well as for the antigen, the RNA and the antigen for the virus. I'd like to know, each of you, what you think about that, and is that really the answer to the backlog of testing?
So a couple of points to this. A lot of the rapid assays that are available, particularly the rapid antigens, state that if you get a negative result, you can't rule out infection, and therefore you'd have to follow up with a PCR assay to really rule out a true infection. And so if you've got a very low prevalence of disease, it doesn't give you a lot of benefit to do a rapid antigen test if you end up having to reflex 99% of them to your PCR assay. So that doesn't necessarily save you a lot of time and resources there if you can't trust your negative test result. A lot of these assays aren't particularly high throughput. And so if you're at an institution like VCU, where we have very high throughput molecular assays, which are very sensitive, our average turnaround time for our test is about 10 hours. Almost all of our tests are done in under 24 hours, and we do have some limited rapid reagents available where we could get a result in under 30 minutes. So I think for us, a good strategy has been trying to reserve our rapid molecular assays, which are still performed in the lab. We're not using them as a point of care. They're in our central laboratory for our patients who really need to have a rapid answer up front. And a good example for that is our transplant patients, because we need to know before they go into their transplant and before they're immunocompromised if they're going to have COVID-19, which is not something that you want to move forward with immunosuppressing those patients. So for us, we've been trying to use our molecular assays strategically. And anytime you've got point of care assays out in the field, that means you have to train additional people and they have to perform everything correctly. There's actually a lot of complexity to these tests and making sure everything's in line and you've got the right certifications to perform them. It's also hard to get some of these rapid antigen assays. So even though they're available widely in the news and the media saying, look at this great 15-minute assay that we have available, a lot of them are reagent limited, just like everything else that we're doing. So I think you have to balance what are your hospital's actual needs or whatever clinical practice you're in. It might not necessarily be a hospital, that's just my experience, and try to understand, is a little bit of lower sensitivity rapid antigen testing going to be useful in certain scenarios, or is that not necessarily worth the extra effort in having to confirm those answers?
Good points. Dr. Toney, do you think that there's a place for the point of care rapid tests outside the hospital perhaps, or are they going to run into the same problem that the hospital does?
I agree with what Dr. Bryson said. There are pros and cons to it. Many of these point of care tests lack sensitivity. And so you do run into the situation where you could get false negatives. I think you have to balance the benefits of the rapid point of care is when you're in situations where we do have areas that do not have readily access to testing, to have access to a point of care test that can give them immediate results. If that's the only access to testing they have, as compared to having to send off a test where they have a 10 to 14 day turnaround time, then the benefit is having a test that may have poor sensitivity, but at least they're getting a test result, because many of these, if they get a positive, it is a true positive oftentimes. And so they do get the benefit of getting laboratory testing where they wouldn't have a laboratory test result otherwise. So I do think if they're used in the proper setting and in an area where the prevalence is higher, they are good tests to be able to place in areas that need access to testing. I do think if it's in an area where the prevalence is low, or if it's in an area where you need high sensitivity, I would personally think that they would not be the best choice, because again, you have to reflex it to have a confirmation if they are negative.
Mm-hmm. The last time I looked, I saw that there was over 700 different test products being marketed for COVID-19 testing, and less than, or maybe about 10% of them have actually received emergency use authorization from the FDA. A lot of people think that if you just develop a test, you can just throw it out there and get good results. But in fact, in order to get approval from the FDA to use it, tests have to be validated. And the validation process is not a quick thing to do. Can you and Dr. Bryson tell us what do you need to do to validate a method? In other words, let's say somebody develops a brand new method. What do they have to do for it to actually be reliably implemented in the clinical setting? And I guess you have to get reference specimens to perform the validation with, and how do you get those reference specimens, and how many do you have to do?
The FDA guidance for EUA submission, which is the process that laboratories have been going through, has been changing and evolving throughout our time. So the initial EUA submissions that went in had fewer specimens that needed to be performed. We actually got an aliquot of unknowns from our state health lab to validate our initial assay. So they sent us some positives and some negatives without telling us which ones were which. And we had to run our lab developed test, give them the answers, and they came back and confirmed for us that we had in fact gotten the correct designation of a positive or a negative test. So that's what we submitted for our EUA approval. As time's gone on, they've actually added on additional requirements, and I know that changes with some frequency. So I don't know the exact number cutoffs that are currently in place by the FDA, but they do have those listed on their website. And you do have to do this validation for even different specimen types. So if you want to look at saliva as a specimen type versus a nasopharyngeal swab, you need to do that comparison. We know the nasopharyngeal swabs are a good specimen. You would have to do a side-by-side comparison of saliva and nasopharyngeal swabs collected at the same time to really do the best study to confirm, okay, now I've validated saliva as a new collection specimen type that can be used. We also look at cross-reactivity. So there are other coronaviruses that circulate and cause the common cold. So one of the most important things to do is make sure that your molecular assay doesn't cross-react with any of the common cold coronaviruses or with SARS or MERS and give you a false positive result. So it's important to test your molecular assay against other common respiratory pathogens, because the people who are going to be getting these tests should be presenting with respiratory specimens. So you need to make sure influenza doesn't cross-react with your assay.
And I'll just add too, I think that's one of the responsibilities of a laboratory director. When you take responsibility of a laboratory, it's your responsibility that test results that you release from your laboratory, especially if it's being used for clinical diagnostic purposes, that they meet a level of quality. I know the federal government, FDA sets standards, CLIA has standards, and I know with the COVID pandemic, there have been changing guidance and lessening guidance, but Again, as a lab director, that sets the standard, but it doesn't mean that you can't have a higher standard for validation to include sensitivity, specificity, reproducibility, precision, accuracy. These are things that I personally feel that every test that comes out of a laboratory for clinical purposes should meet in order to ensure that when you are reporting results that are going back to a patient, you have confidence that they are accurate and that your employees have the ability to do it over and over again with the highest level of accuracy, regardless of what the benchmark is for FDA. And I think that level of quality should always be maintained for these tests, regardless of whether it's released under emergency use authorization or whether it's a fully fledged laboratory developed test or, you know, an FDA regulated test.
Thanks. So it sounds like validating a new test method is a lot of work. And that kind of segs me to my last prepared question, and this is for Ms. Mercer. There's a general shortage of certified medical laboratory scientists to staff hospital labs and reference labs. How has the pandemic impacted your ability to meet the demand for testing for the virus, and also while continuing to provide all the other clinical laboratory tests that are needed for healthcare in the hospital?
Sure. So fortunately, or I guess unfortunately, we saw a decrease of about 35% in our overall testing volume after the Virginia stay-at-home order. So this really afforded us time to, you know, plan how we would manage not only all of the validation work and bringing the test in, but all of the additional training associated with COVID. And I'd also add that one thing that COVID did for us, I think as a profession, it really did highlight the lab. And so we have garnered such tremendous support from hospital administration, our medical staff, because of the testing that we're able to provide. So, I mean, I think this is important, and I'm really hopeful that as we are in the spotlight, it'll bring this profession more to light, and we'll get more interest in our medical laboratory science program, and we'll increase our enrollment. So I think even though it has strained us to some extent, as far as, you know, especially as we reactivated our volumes, we're almost back to where we were pre-COVID. So not only do we have the demand of COVID, but we all have all of our other testing coming back online. It really has been a total team effort, and I think we have some wonderful people in our lab who have been very dedicated to make all this happen.
Thank you. So I'm going to throw some questions at you that have been coming in over the registration and also while we've been here online. One of the questions is, what is the difference between collecting the specimen via throat swab, nasal swab, a nasopharyngeal swab, or collecting sputum? Or does it make a difference, or is there one preferred method of specimen collection?
I would say we don't have the ideal side-by-side comparison data that we want to make concrete conclusions about that. The nasopharyngeal specimen is a very high quality specimen. We use that for other respiratory pathogens. The data for nasal swabs or mid-turbinate swabs really look like they're very similar sensitivity, maybe slightly less. And then the data on the saliva also is a little bit mixed. The sensitivity for saliva compared to a nasopharyngeal swab kind of varies between anywhere from 80 to almost 100% sensitivity. So we're still kind of looking for well-done studies to kind of help better define that. For specimens like a bronchoalveolar lavage, sorry, BALs. One thing that we even see with our routine respiratory pathogen panels that we perform is sometimes you'll have a negative nasopharyngeal swab and you could have a positive BAL specimen. And particularly as this disease sort of progresses down to the lower lungs, there are opportunities for lower respiratory specimens to provide some value. And we know that's true with other respiratory pathogens. The oral swabs, I think, tend to be thought to be one of the less sensitive methods that are available, but again, still waiting on data. I don't know if Dr. Toney or Dr. Freeman have any other comments on specimen type comparisons.
No, I think you did beautifully. I would only add that whenever you are testing for disease, you want to try to collect a sample where the specimen is likely to be found. So in that case, if for whatever reason a person has a pneumonia, you're going to want to collect a sputum. As Alexandra, Dr. Bryson did state, the nasopharyngeal swab is the gold standard and typically the best swab for any type of respiratory infection.
Thank you. Eleanor from Altoona, Pennsylvania wants to know what is the most accurate method out there, and I will add to that, for the methods that you're using, is there much of a difference in accuracy?
I would say among the 5 different molecular platforms that we're using, they all have very similar performance. And I would estimate the sensitivity to be over 97, 98% sensitive for the vast majority of these well-vetted diagnostic tests that are either coming out of commercial labs or their laboratory developed tests from high complexity laboratories that have a lot of experience for doing this. So I think the majority of these reputable assays are very sensitive and also highly specific. We really don't think we're seeing a lot of cross-reactivity, particularly with other coronaviruses for these assays. So I don't think we could name one of them as being significantly better than the other. And you do, I was going to say, you do have to be careful. There are some published studies from across the world where people do have some inferior tests that they've put together. So those things are definitely out there, but I'd say if you're using a reputable diagnostic company, they've all been performing quite well.
Thank you. Jenny from Ashburn wants to know about different testing options and how is that going to relate to vaccine safety when the vaccine comes out. Do you think any of the tests that we're doing now may have any application in that type of research? Dr. Toney, do you have any opinion about that or any preliminary data?
What I can say with respect to the testing that we're doing now for relating to the vaccine development is, and I can speak to work that we're doing at the state lab, is one of the initiatives that we are participating in that has nothing to do with diagnosis of the virus is we are conducting studies looking at genome sequencing of the virus, where we are taking subsets of specimens from different outbreaks from different regions of Virginia, and we are conducting full genome sequencing of the virus, or are conducting next generation sequencing on the virus to try to analyze the regions of the virus, looking for the different clades, looking for mutations, looking for genomic variants. And all of this information is being uploaded into some national and international communities where other folks are doing the same thing. And what that is allowing us to do is to have a better characterization of the strains, if you will, of the types of introductions that we're seeing. We're looking at the genetic divergences of the different viruses that we are seeing in outbreaks. This allows us to understand transmission in our community. It allows us to understand when we're looking at a given outbreak, whether we have a single introduction of a virus clade, or whether we might have different introductions of different viruses into an outbreak population. And so if we are looking at these different viral sequences, that's the type of information that individuals that are looking at vaccine production would use as they move into vaccine production. We do something very similar with influenza vaccine production, because you don't want to target an area that looks as if it is prone to high mutation, because then that would mean if you targeted that for vaccine production, that it would mutate outside, and then the vaccine would no longer be effective. And so we're very hopeful that our sequencing efforts, as well as those from other laboratories, will help inform better decisions for vaccine production.
Excellent.
And I was going to say, one thing to add on this topic as well is, if you're looking for somebody's immune response to a vaccine, the antibody assays that are out there, some of them look at the spike protein, some of them look at the nucleocapsid protein. So if you have a vaccine that's only going to produce one of those antigens, and you're only going to make antibodies to one of those antigens, if you're making antibodies to the spike protein and you're looking for an immune response, you'd want an antibody assay that looks for antibodies to the spike protein. So that's just one thing to keep in mind. And as more people get vaccinated, our seroprevalence information kind of changes. So at the moment, if we do seroprevalence studies on the general population, nobody's vaccinated. So we get an idea of how many true infections are out there. But once people have immunity to the vaccine, it can be hard to know, was that a natural infection or was that from the vaccine, unless you kind of dig into more of the specifics.
Mm-hmm. Here's an interesting question from Anud. We've heard about the COVID SARS-CoV-2 virus also causing other types of problems in the body besides respiratory infections. So what future testing is in the works for associated coagulopathies in the clinical laboratory? Have we seen any of those coming in? Roxanne, do you know about that?
I'm not aware that any requests have come our way.
So there hasn't been an uptick in coagulation testing there?
Not that I've seen, and
Okay.
looking at our numbers.
Okay. Dr. Freeman, are you aware of any such happenings?
So, no, I'm not particularly aware of any specific happenings. I will say that one of the diseases that they are thinking is correlated to infection with COVID-19 is multi-system MISC. I'm sorry, I'm forgetting the acronym at this point, but multi-system disease related to coronavirus. We have partnered with the Virginia Department of Health in a few cases in order to determine whether or not people who are suspected of having this multi-system disease related to coronavirus have antibodies for coronavirus. And so we have been working to do that. The research is very early. They have not been able to make specific associations between coronavirus disease and then this later development of the multi-system disease failures, but that is ongoing. And so we have participated in a little bit of antibody testing in order to assess whether that is occurring.
Mm-hmm. Now, let's see. This question isn't so much about lab testing, but perhaps it may be some information here. Some people say that the virus sticks to doorknobs and sticks to countertops and things like that. Have there been any studies that show how long the virus remains active on inanimate surfaces? Are any of you familiar with any such studies?
So when looking to information like that here at the state laboratory, we really do rely on the information that's provided for the Centers for Disease Control and Prevention. That information is actually readily available on their website, where I'm not sure that CDC has actually done the investigations, but they have worked or partnered with locations that have looked at different types of surfaces and how long the virus may stay viable on those surfaces. And so that's really the best source of information.
Chuck has a question. What is your opinion of the CDC's guidance that says that asymptomatic people don't need to be tested? Is that an accurate representation of what the CDC is saying? And if so, what do you think about that? Or should testing be conserved for patients that have symptoms? I know that's loaded.
Yeah, so this is an incredibly new statement that just came out of the CDC. And so I think a lot of us are still looking into what the background data for this is. But you do have to kind of balance what we should be doing for testing. In general, the positive predictive value and negative predictive value on a test is really dependent on the prevalence of your disease. So as a general rule in infectious disease, we don't intentionally test people who we don't think have the disease because it changes your positive and negative predictive values of these assays. So we don't test asymptomatic people routinely for other infections. So it's a little bit new that we're doing this for COVID-19. I think there's some role for testing asymptomatic people. Again, if you're a transplant patient, you're about to receive a transplant, you're going to be immunocompromised, that makes sense to perform some asymptomatic testing up front there. If you're going to have an aerosol generating procedure that's done in the hospital where if you were COVID positive, maybe they would use extra precautions. A lot of places are using those extra precautions anyways. They don't necessarily need that test to drive what their precautions are. And so really you kind of have to look at, do we think having a positive or negative test in an asymptomatic patient, is that actually going to change whether or not we would perform any sort of procedure? And I do think there's a little bit of an ethical question that everyone in our field is still trying to work through, and making sure that people have rapid turnaround times who actually are symptomatic and really need access to the test. So I think the most important thing is for us to be meeting the needs for people who actually need symptomatic testing and being able to provide a meaningful turnaround time. I know I was just looking at our turnaround time data for the reference laboratories for the state of Virginia earlier this week, and it's actually gotten pretty good again. It's back to about 2.5 days for turnaround time, which is excellent. I know we've gone through periods where people are waiting for 2 weeks, and maybe the public health side can speak a little bit more to testing asymptomatic patients or asymptomatic individuals from their perspective. But it is, I think it's a complicated question that doesn't necessarily have a straightforward answer, and it depends upon if you're meeting the needs of those who need this testing first, and what good and what impact you actually think you're going to be able to make with asymptomatic testing.
And I think I'll just add, everything Dr. Bryson said, I completely agree with. I think there are two types of asymptomatic people. I think that the testing, just the broad testing of large populations of asymptomatic folks, there was a time and a place where there was not available access of testing. A lot of hospitals were incurring issues with lack of availability of test kits. And so to utilize testing reagents that were in limited supply to do widespread widespread community testing of asymptomatic individuals did not seem to be prudent when we couldn't test symptomatic hospitalized individuals because there wasn't available test kits. It just did not seem right. I think the other thing to take into consideration is many of the test kits that are out there are not approved for testing of asymptomatic individuals. So it would not be an approved sample type or a population to test asymptomatic individuals because the test kits had not been evaluated for their accuracy in that population. So that was another consideration. So I think you have to look at the population, but yet if you had asymptomatic individuals in a cohort where there had been potential exposure to positives, then I think that that's a very different situation in wanting to test those individuals. So again, I think the guidance is always changing, and a lot of it has to do with the availability of the test at the time that testing needs to happen.
Thanks.
And just to add on one more thought to this, our supply chain really is not set up to handle this amount of molecular testing right now. And so we're seeing other areas that aren't COVID testing start to suffer. And a couple of examples, we have a PCR assay to look for methicillin-resistant Staph aureus. And those reagents are now on short supply because all of the PCR reagents are being funneled towards more and more COVID diagnostics. Same thing for gonorrhea and chlamydia. We use a molecular assay to diagnose that. And again, all of those reagents that normally go into building those tests are being funneled towards COVID testing. So we start to see negative impacts on our supply for other diagnostic testing just because our system isn't set up to handle this extreme burden. So you do have these trade-offs. If you end up testing wide swaths of the population, you're giving up those reagents somewhere else that might be needed for something. So you just have to always balance and counterbalance what you're doing.
Yeah, and if I can restate what you and Dr. Toney have said, if you are testing a population where there's mostly asymptomatic individuals and a very low prevalence of the disease, doesn't matter how good a test you have, you're going to get more and more false positives than you're going to get true positives.
Yes, absolutely. And that's true with any test, not just COVID.
Right. So Dr. Graybeck, is the too much fun alarm gone off, or do we need to wrap this up?
I know, I hate to end it here. There have been so many questions that we've been trying to get to. So I want to say thank you for tuning in. I know I learned so much. And thank you to our moderator, Dr. Bell Corzin, and each of our expert panelists. VCU alumni, faculty, staff, and family members of current students appreciate your expertise and experience you bring to this topic. Your time is incredibly valuable, as we know and recognize. You've been working the front lines during this pandemic, so we are so grateful for the work that you do, the awareness that we can build about your profession and the work that you do, and we want to thank you for answering our questions live today. We will be reposting this webinar to Facebook and YouTube with closed captioning for later viewing. For those on the webinar, we will be sending a follow-up email tomorrow and providing links to resources mentioned in this webinar. We have linked to a survey in the chat box, and so we'd appreciate if you could complete that survey. We truly value your feedback, and we want to know what we should keep doing more of and how we can improve what we're doing. If you've enjoyed listening and learning from our alumni and expert panelists, please consider supporting the Medical Lab Sciences Department at VCU and the College of Health Professions. There are several ways to support its programming, research, and continuing education opportunities during this critical time. If you yourself work in a lab and have leftover medical supplies, please consider donating those to the department. If you're interested in sponsoring a class or naming a room in the new beautiful building or giving to the department directly, please contact Trevor Warden, the Leadership Engagement Officer for the College of Health Professions. His contact information is listed in the chat box, as well as on Facebook. Trevor Warden, T.A. Warden at vcu.edu. Everyone loves him. You will love him. And you can also give straight to the department in the link that I shared. Thank you again, Dr. Corzine, our expert panelists, and we will see you soon. Go Rams!